Welcome everybody. I think we can start this session with entitled Ocular Tumors Management Challenges. We have 10 speakers to deliver the talk at this session. So let's start with the first speaker. Are you there, Dr. Ji Yong Kwak?
Yes, I'm here.
Okay, 8 minutes for you.
Okay. Hello everyone, my name is Jae Kwak. I'm from Gangnam Severance Hospital in Korea. Today I'll be talking about a case of pediatric vitreoretinal lymphoma focusing on initial presentation, treatment, and clinical challenges. So I don't have any conflict of interest to declare. So this case is from our Professor Christopher Lee. And it's a female 9-year-old who first visited us in April 2023. She had a history of bilateral uveitis from 2020, and sadly her mother died of brain metastasis of non-Hodgkin's lymphoma. And she had undergone diagnostic vitrectomy at a different hospital 3 months ago, and the biopsy showed diffuse large B-cell lymphoma. And she visited us for second opinion. In baseline, her visual acuity in her right eye was 8/20, IOP normal. She had keratic precipitates in her right cornea, vitreous opacity and cells, and hazy fundus in her right eye. Her left eye was otherwise normal, except that she had undergone vitrectomy. Previous imaging showed no CNS involvement, and PET scan done before vitrectomy showed FDG uptake in both eyes. And our plan was to do diagnostic vitrectomy in her right eye. Ultra-wide imaging showed very thick vitreous opacity, and that has been covering the angiogram in her right eye. And the vitrectomized left eye showed a diffuse pinpoint leakage. Just to show you the operation briefly. So as you can see, she has very thick veil-like vitreous opacity in her right eye. And Chris is finishing up the case with fluid air exchange. So we sent the vitreous for analysis, and cytology showed CD20 positive B-cell clusters suggesting DLBCL. Her IgH and IgK showed monoclonality. IL-10 over IL-6 was greater than 1. And NGS target panel showed mutations in CDKN2A, CD58, PRMDM1, and CD70. All these were tier 2 according to ACMG criteria. So this was a publication done by us 2 years ago. We did NGS panel sequencing of adult VRL patients. And 3 of the 4 mutations found in this young patient was among the common mutations reported for adult VRL patients. So over the course of a year, she had undergone 10 injections, 10 methotrexate injections in the right and 9 injections in the left. And both eyes did not show signs of recurrence. However, whether to begin systemic treatment required a multidisciplinary approach. And from May 2023, her MRI showed progression and regression of her lesions in the brain. By May 2024, she had developed new neurological sign, which was left facial palsy and left hand and foot coordination abnormality. And that's when pediatricians began referring her to neurosurgeons, and they did a brain biopsy. However, it showed non-specific focal gliosis with focal perivascular lymphocytic infiltration. And the neurologist began steroid treatment for CNS angioitis. However, in August, they stopped steroid because her autoimmune antibodies were negative and there was no response on her brain MRI. And her brain imaging from August actually showed progression of lymphoma on lymphoma, and they started chemo for CNS lymphoma. And in September, the MRI showed favorable treatment response. And by November, she had finished 4 cycles of chemotherapy. And in December, she had undergone peripheral blood stem cell transplant. And until now, March 2025, or MRI results was favorable. So vitreoretinal lymphoma is a subset of CNS lymphoma, as you all know, and CNS lymphoma itself is very rare in children. And the incidence is only 15 to 20 cases per year in North America. And it's a non-Hodgkin's lymphoma with high morbidity and mortality. It's more prevalent in the elderly. And there has been only 4 cases of pediatric VRL in the literature since 1980s. Just to sum up, although rare, VRL should be ruled out in pediatric uveitis patients when they show bilateral involvement, curtain-like vitreous opacity, and maybe possibly a family history. So this case was a first confirmed pediatric VRL patient diagnosed by both vitreous cytology and NGS. And NGS has proven invaluable for early diagnosis, and in our case, it was pivotal in confirming the malignancy. And a multidisciplinary effort from the initial evaluation is essential, as systemic involvement is common. And thank you all for listening.
Thank you, Dr. Kwa. We'll have questions at the end of the session. You may wait in the session hall. We have the next presentation by Dr. Duanate Rojanapan from Thailand. She'll be speaking on the topic management of intraocular vascular tumors for 8 minutes.
Thank you very much for the kind introduction. It's my great pleasure to be here. These are my financial disclosure, and none is relevant to this talk. Retinal vascular tumors generally include 4 distinct lesions: racemose hemangioma, retinal cavernous hemangioma, retinal vasoproliferative tumor, and retinal capillary hemangioma. One main point to differentiate this lesion is its congenital or acquired in origin. The congenital retinal vascular tumors include retinal cavernous hemangioma and the racemose hemangioma, which endothelial cell tight junctions are usually intact. Therefore, there is no exudation or leakage seen clinically. In contrast, acquired retinal vascular tumors, retinal vasoproliferative tumor, and retinal capillary hemangioma may have impaired or lack of tight junctions and commonly present with an exudative component. Let's start with racemose hemangioma, which is a benign retinal AVM. It could be isolated or related with systemic AVM in many organs, including brain and others as listed here. 30% of racemose hemangioma patients had brain AVM. It is important to evaluate the patient for systemic AVM. The patient can develop retinal complications such as vascular occlusion, neovascular glaucoma, or hemorrhage. This is our racemose hemangioma patient who developed CRVO and macular edema, which resolved after intravitreal bevacizumab injection. The second tumor is retinal cavernous hemangioma, which appears as a cluster of grapes. Epiretinal membrane or surface gliosis over the tumor may contract and cause hemorrhage. We have to check the family members and evaluate for systemic hemangioma at the skin or CNS. If the patient has bilateral disease, 70% of them has family history. So there's no specific treatment for the tumor. Vitrectomy may be required in cases with vitreous hemorrhage. The third tumor is vasoproliferative tumor, or VPT, which appears as a white, yellow, or orange-red retinal tumor. The feeder vessels can be tortuous but not dilated. Serous retinal detachment, exudates, hemorrhage, or RPE changes can be seen around the tumor. The tumor can be isolated, so-called primary VPT, or associated with other ocular diseases such as COAS, retinitis pigmentosa, FEVR, so-called secondary VPT. VPT usually locates in the periphery, but can cause maculopathy in up to 25% of the cases. Inactive tumor can be observed. Treatment should be done in active tumor. Vitrectomy is indicated in vasoproliferative tumor with EMM, vitreous hemorrhage, or RD. For small active peripheral VPT, triple freeze for cryotherapy is an effective treatment, as you can see in the resolution of subretinal exudates and serious RD in this patient after following cryotherapy. Another case of small active secondary VPT from FEVR successfully treated with cryotherapy. Usually VPT locates in the periphery, but for small active tumor in posterior pole, like in this patient, where cryotherapy may be difficult, we can use PDT, and as you can see in this patient, and this is the another alternative effective treatment. For thick or large VPT, brachytherapy is preferred, as you can see in the tumor regression and resolution of RD and exudates following ruthenium brachytherapy in this patient. Another case of Coats disease with large secondary VPT. The tumor regressed well after ruthenium brachytherapy. The last tumor is retinal capillary hemangioma, which appears as orange-red retinal tumor with dilated and tortuous vessels and drainage vein. Associated serous RD, exudates, ERM or tractional RD, as well as secondary glaucoma or uveitis can occur. If it could be isolated or associated with systemic von Hippel-Lindau disease. Genetic study of for VHL gene mutation should be performed if there are multiple tumors or family history. If the patient has VHL disease, they are at risk of having other organ tumors as listed here. Inactive or fibrous tumor can be observed, but timely treatment should be applied in active tumors. For small peripheral tumor, cryotherapy is preferred. For large or thick tumor, brachytherapy is required. Vitrectomy is indicated in cases with tractional RD, like in this VHL patients with multiple tumors and tractional RD. The patient has done well following vitreoretinal surgery for tractional RD and cryotherapy applied to the tumor. The systemic HIF-2 alpha inhibitor, belzutifan, has been approved for use in patients with VHL disease associated with renal cell carcinoma, CNS hemangioblastomas, and pancreatic neuroendocrine tumor, and show great promise for controlling retinal capillary hemangioma and preventing visual loss in patients with VHL. But further work is needed. This is the largest case series now in ocular pathology. Oncology and pathology. In conclusion, patients with retinal vascular tumors should be worked up for any systemic or ocular condition associated with the tumors. Proper and timely treatment for tumor-related complications and treatment for the tumor itself can lead to good patient's outcome. Thank you very much, and for the memorable moment in India.
Thank you. The next speaker will be Dr. Santosh Honaba. He will be talking about ocular surface tumors and role of brachytherapy.
Okay, before Santos, while waiting for Santos, just for your information, because we have quite a lot of speakers today and we have limited time. So I believe that you have a lot of questions, but we want to have a QA at the end of the session. Thank you.
Good afternoon. I'll be speaking about the role of plaque brachytherapy in ocular surface tumors. Historically, about 25 to 40% of ocular surface tumors recur following surgical excision, thus precluding vision salvage, eye salvage, and each recurrence adds to metastatic potential. That is the reason why we need to have fewer number of recurrences, and we depend on several oncological principles. One of the most important oncological principles when you surgically excise an ocular surface tumor is edge and base clearance at surgery, and if required, histopathology guided adjuvant therapy. I'll be stressing on these aspects. While edge is easy to determine, you can see it on slit lamp evaluation, base is opaque. You can clinically evaluate the base by trying to move the tumor with a wet cotton tip applicator. That's all. But beyond that, how do you know how deep is the tumor? In such a situation, OCT and UBM come to help. They'll be able to tell you the depth of the tumor and if there is any scleral or corneal stromal invasion. As you see here, this patient has normal stroma here, whereas under the tumor, the stroma is splayed and also hyperreflective, indicating that the patient has full thickness corneal stromal involvement. The only way we can deal with it would be either a penetrating keratoplasty or perhaps plaque brachytherapy. So you don't have a clinical clue when the tumor is opaque. Good news is that imaging correlates very well with histopathology. Here you see a situation where the conjunctiva is involved, tenons, that bubbly layer, is not involved, and that's exactly what you see on histopathology. So when there is good clinical imaging correlation on histopathology, it's easy to determine scleral invasion. But there are clinical situations where scleral invasion may not be detectable because the tumor may have excessive keratin that causes shadow artifacts. In patients who had scleral or limited intraocular extension, earlier we were considering extended enucleation or orbital exentration. Perhaps now we can consider plaque brachytherapy. We use ruthenium, which is a beta emitter. And before you begin plaque brachytherapy, you have to determine whether you want to do it as a primary situation or a secondary situation. Primary plaque brachytherapy always follows this strategy where you confirm the diagnosis on clinical evaluation and, if required, do an incisional biopsy. Primary plaque brachytherapy is reserved specifically for situations where if you want to excise the tumor, there could be loss of integrity of the eye, such as patients with a corneal stromal melt, patients with a necrotic tumor. Where you try to excise this tumor, you will have a corneal scleral perforation, which is not easy to repair. In these situations, we go for a biopsy from a safe zone, confirm the diagnosis, and treat rest of the tumor by a primary plaque brachytherapy without even excising it. So clinical diagnosis followed by exact measurement of the tumor, followed by measurement of the depth of the tumor, and then dosimetry for the estimated height of the tumor, surgical excision and insertion of the plaque. This video clip shows the excision of mucoepidermoid variant of ocular surface cutaneous neoplasia, which has recurred thrice over multiple surgeries done elsewhere with no base clearance in previous surgeries. Although the base was reported positive by the pathologist, the prior surgeon did not take care of it by adjuvant therapy. And patient promptly had a local tumor recurrence, multifocal local tumor recurrence, over a matter of 3 months. And again, the patient had involvement of the insertion of the extraocular muscle as well. This was a desperate situation because the other eye was a case of childhood trauma and the patient had poor vision in the other eye, and this eye fortunately had good vision. So we are hooking the muzzle, that's the lateral rectus. We are disinserting the lateral rectus muscle. We are excising the part of the lateral rectus that was involved. So we do an MRI to see the extent of the muscle involvement as well. Excise the tumor in flush with the scleral surface, not doing any sclerectomy at all so that we don't lose the tectonic support of the sclera. Apply plaque to the base of the excised sclera. Then if the larger area needs to be covered, we can easily rotate the plaque. Rotate in the sense we remove it at the end of the exposure and apply the plaque again to a different area. So that is definitely possible. So with plaque brachytherapy, we were able to give good success to this patient who had full thickness scleral invasion. This is the post-operative outcome. This is a patient with full thickness scleral invasion, again with treated with plaque brachytherapy. Corneal stromal and scleral invasion with OSSN treated with brachytherapy. Corneal stromal invasion and anterior scleral invasion treated with plaque brachytherapy. Now, this was a patient with necrotic tumor and corneal stromal melt treated with primary plaque brachytherapy, and this is the outcome. So we don't have to worry about completely excising the tumor as long as the plaque can be easily placed over the tumor. This is one more example of primary plaque brachytherapy. Of course, there are complications. Limbal stem cell deficiency is an issue, so we currently do primary simple limbal epithelial transplantation in these patients where there is extensive involvement of the limbus. In conjunctival melanoma, of course, we can do plaque brachytherapy. The process is the same. We estimate the thickness of the tumor. We do a UBM to see if there is any ciliary body involvement. This patient does have ciliary body involvement, as you can note, but it is still treatable. The steps are the same. I'll skip the video for lack of time, but this patient was treated with brachytherapy. Extensive conjunctival melanoma arising from prior excision did not take care of the margins or the base, and the patient has multifocal recurrences, all of which was excised, and the scleral involved area was treated with brachytherapy. This patient has a scleral invasion, again treated with excision and brachytherapy, doing well. Extensive conjunctival melanoma with partial scleral involvement treated with brachytherapy. So in summary, I would say that Tumors with corneal stromal or scleral invasion or limited anterior segment invasion need multimodal approach. They need to be excised, of course, with 4 millimeter clinically clear margins. Lamellar sclerectomy is optional. You can excise in flush with the sclera. I would not prefer to do lamellar keratectomy at all. Alcohol-assisted keratoepithelectomy is only for the corneal epithelial component. Double freeze thaw cryotherapy, as usual, goes to the edge, not to the base. Adjuvant plaque brachytherapy in a primary or a secondary sitting would definitely help you reduce the local tumor recurrence rate. Of course, finally, there is histopathological correlation. Thank you so much.
Thank you, Dr. Santos. Very impressive presentations. We are lucky today because we have Dr. Santos as one of the speaker. I believe that if you have question, this is the good opportunity because I recheck that Dr. Santos will be here until the end of the session. Is that okay? Okay. Okay. So the next is also a very famous speaker, Professor Arun Singh, who will talk about chemotherapy in retinoblastoma. We have quite a lot of option for application of chemotherapy in retinoblastoma. And then the question is which route? 8 minutes for you, Dr. Singh.
Thank you very much for the privilege. It's always fun to be here. So in retinoblastoma, we always think of chemotherapy as the primary treatment nowadays, but we must not forget when to do enucleation, because we know enucleation is still the most common treatment across the globe, even in developing nations like United States. So it's not that the enucleation has disappeared, it's just that nobody's talking about it anymore. So my talk is therefore to emphasize the continued role of enucleation that has been used for retinoblastoma for more than 150 years. So let's talk about just general criteria. We say is unilateral group D or E disease. I think thing to focus is the vision potential. In my opinion, if there is vision potential, it's worth saving the eye, and if there's no vision potential, we talk about that, then you really don't think you can say it's worth all the effort of putting the baby or child through 30 EUAs and expensive treatments in some parts of the world. I think presence of neovascular glaucoma, extraocular extension based on imaging are also clear criteria for enucleation or modified treatment, and also to large extent the anterior chamber extension, perhaps exception being a monocular patient. So let's look at a case here. In this case, there's neovascular glaucoma, and there's no view to the disc and macula. You can see the eye is full of tumors, group E disease. No matter which classification you take, I would say that's a good case for enucleation. Let's move on very quickly to a case of when you might think primary IVC. I would say a child less than 3, because technically it's difficult to do IAC in a child that young. Patient has bilateral disease, perhaps is better. And again, keep in mind the vision potential, groups B, C, and D, for example. So look at a patient here with a nasal tumor with extensive seeding in the right eye across the macula. The disc and macula are not directly involved. And the other eye has a group C disease. So I say this is a good candidate for intravenous chemotherapy. Both group B disease on the left eye, both eyes were treated with intravenous chemotherapy, and patient did very well. But look at the patient here, has a unilateral disease, has a vision potential because here the tumor is nasal, inferior nasal, there's diffuse seeding across the macula, but the macula is not directly involved. The retina is normal under the seeds. So it's a unilateral case, it's maybe a year or 2 years old, and there's some vision potential. We know in group D disease, with the data coming out of China, in a randomized trial, that IAC is a superior primary treatment than IVC. So we chose IAC for this case, and patient did very well. You can see the tumor, nasal tumor shrinking very nicely. It's a unilateral disease, and patient recovered very good vision, of course combined with intravitreal chemotherapy, in this case mostly melphalan. Seeds went away, patient had very good vision. So again, it's not the problem is not the treatment, it's the case selection. You say IAC did not work, well, there's something wrong in selecting the patient. Look at this patient again, 12-month-old, total retinal detachment, but there's no extraocular extension. It's a 12-month-old child, and one could have enucleated this case, but again, parents have preferences for not having the enucleation. This eye was treated with IAC, and you can see all the complications of IAC with extensive vision loss, choroidal atrophy, and optic atrophy. So IAC may save the globe, doesn't give you vision necessarily. We say about 10-20% of cases will have severe vascular complications. So if this case was one eye had been enucleated and this is the only eye, the child is blind basically. So keep in mind that ISE isn't going to give you vision necessarily. So here's another case who is 3-month-old, has unilateral disease, and we thought IVC is okay here because the child is young, and we find in a hospital ISE is difficult in younger children, and the patient did very well. You can see that here the nasal tumor, kind of inferotemporal tumor, fell away from the macular area. But this is a case, again, unilateral disease, extensive neovascular glaucoma, filling the globe. It's unilateral, no chance of vision here. There's really no view of disc or macula. The eye was enucleated, and there's neovascular glaucoma. So, and this case had extraocular extension on histopathology and even choroidal invasion. So if there's choroidal invasion, we know enucleation is not enough. So you can choose different cases, different treatments, and perhaps give the best outcomes. But of course, you have to discuss with the family, offer them what you can, give them the rationale that you have. So why you're doing it, I think that's very important. Not just what you're doing or what you're recommending, but why you're recommending their treatment. Please tell them that. That's very important. And of course, realize that a child who receives conservative therapy on average will have 30 EUAs. Every month for 3 years or so, they'll be checked up. So think about the burden of travel costs and multiple anesthesia. It's a long-term journey. It's not just one treatment, one opinion. And of course, it depends upon the means and expertise that you have. So you can only make choices based on where you are and the choices you have. Thank you very much for the opportunity.
The next speaker will be our chairperson, Rita Sitos. She'll be talking about RB treatments. Can we avoid radiation retinopathy?
Okay. Yes. Today I would like to share with you RB treatments. Can we avoid radiation retinopathy? So I have no financial disclosure. As we know that radiation retinopathy is a significant complication of radiotherapy in RB patients. It is characterized by progressive damage to the retinal microvasculature due to injury to endothelial cell. And this may result from microvascular occlusion and leaking capillaries, usually occurring several months after the radiation exposure. This is very important, showing you that the clinical risk factors for the development of radiation retinopathy. The one is prior or concurrent chemotherapy, and the second is size, location of irradiated area. The larger, the more posterior the location of the irradiated area, the higher the risk of the RR, radiation retinopathy. And then extrinsic factors have to pay attention on type of radiation. The RBRT, external beam radiation therapy, have higher risk than more localized modalities such as proton beam therapy. And also the other things is radiation dose, fractionation schedule, and elapsed time in the course of treatment. At this stage, I think I can stop my talk because already answer what is in the title, how we can avoid radiation therapy. But I want to proceed with this, showing you a case. A case with radiation retinopathy as a devastating ocular complication that, as my experience, at first I was doubtful to deliver this case to you because I think this is a bad experience that we have. But on the other side, I believe that, as mentioned here, that bad experiences can be the best teachers, but only if you can reflect on them and learn from them. So Let me continue with this case illustration. A 5 year boy was referred to our hospital in Jakarta from local hospital in the North Sumatra with diagnosis of anophthalmia. Actually, the boy has bilateral retinoblastoma. The left eye was enucleated at the local hospital, followed by 4 cycles adjuvant chemo at the local hospital 3 months prior to admission. He has history of leukocoria for the past 2 years. When he admitted to our hospital, the fundus under right eye showing multifocal tumors and a huge juxtapapillaris tumor, I will show you, and that is the only eye. For a note that we have challenge before we continue, this is the uncooperative parents always undergo irregular follow-up schedule, mostly back and forth to Lampung District Hospital due to familiar reasons. So this is the fundus at the first admission. We can see that there is the juxtapapillaris tumors, multifocal tumor at the first admission, and there is also a tumor and the peripheral. At the time we did chemo reduction followed by TTT and cryo. I know that it should be also IAC, but at that time there is no available IAC at our hospital. So we gave only chemo reduction, TTT and cryo. And then after that, the patient lost to follow up. And by the history, we know that additional 4 cycles systemic chemo was given at the local hospital until he come back, and as showing on the right fundus and the right picture, the tumor looks shrinkage but still big, and then we gave additional TTT. And then the patient lost to follow up again. And we noticed that the patient already have total 12 cycle of intravenous chemo at the local hospital. And when he come back, as you may see, main tumor progress, new tumor in the inferior retina associated with vitreous and retinal seeds. As at the time melphalan has been, an IAC has been available at our hospital, then we give intravitreal melphalan and also IAC melphalan 5 milligram. The result quite good, but the bad news after, the patient was then lost to follow up again following the IAC, and then until return to our hospital with history of additional serial of 2 cycle intravenous, 25 fractionated dose of EBRT at the local hospital with less communication with our team regarding dose plan. So when he came back, I was very surprised showing this fundus, neovascularization, progressive retinal bleeding covering part of the tumor. We didn't apply FFA, not available. And this fundus, this progressive retinal bleeding worsened, progressed to pre-retinal as shown in the right fundus, right picture, hemorrhage covering most quadrant, IOP increase, and at the time we decided to give ranibizumab intravitreal injection. But unfortunately, no improvement following the IFID anti-VEGF, and because there was a proliferative stage pre-retinal hemorrhage, we decided to do enucleation. So what we learned from this case, poor management will result in poor outcomes because lack of good communication with the parents and the referring team. And EBRT should be administered with extremely caution, or strictly said that should be avoided in patients with intraocular tumor who have undergone multiple prior or concurrent chemotherapies, including IAC. And then the indication type, dose, elapse type, if we want to proceed with radiation, should be discussed with oncoradiotherapists very carefully. And I think in this case, fail to control the tumor following multiple chemotherapy. We should consider enucleation rather than to proceed with EBRT. So last but not least, good communication with the parents and the referring team is critical. Thank you.
Thank you very much, Rita. Wonderful lecture. The pleasure of inviting Dr. Hundachov for the talk on choroidal melanoma prognostication without cytogenetics.
Hello everyone, I'm Honda from Taiwan. It's a pleasure to be here and thank you for the kind invitation. And we had a great time in New Delhi as well as Taj Mahal. So thank you so much for Prof arranging everything. Oh, should I need to kick my own slides. So it's my pleasure today to talk about choroidal melanoma prognostication without genetics. So 50% is a figure that we commonly see in uveal melanoma papers. However, for any patient without a prognostication, it is actually 100%. 100% of the patient, they will always be concerned and worried which half they belong to. The power of prognostication in uveal melanoma, we could possibly offer half of the patients with a good prognosis and another half with bad prognosis, unfortunately, but that they can get on with life planning after passing through the 5 stages of grief and work hard on getting early detection of metastasis as well as clinical trial opportunities. The prognostication used to be based on clinical or histopathological features. However, in the recent 2 decades, the genetic features, especially chromosome 3 loss, provided a better stratification between the good and the bad prognosis, and it has become the standard of care in many regions. However, in our part of the world, there are still many barriers. It is mainly due to the rarity of uveal melanomas in Asians. It has made the cost of each genetic test exams to be much higher, and it has made the setting up and the validation of the genetic test in a new laboratory much more challenging. Therefore, we ask ourselves, can we possibly find a surrogate for genetic tests without actually doing a genetic testing? There are possible predictors of chromosome 3 loss listed here, but the most important association is BAP1 mutation. BAP1 is a tumor suppressor gene sitting on chromosome 3p that encodes BAP1 protein, and the BAP1 protein expression can be easily accessed by nuclear BAP1 immunohistochemical staining, which is a cheap, easy, and widely adopted technique in almost all pathology laboratory around the world. In our recent project, we aim at using all these features to predict chromosome 3 loss without actually doing genetic tests. We gather up around 2,500 cases in the Liverpool cohort with a mean follow-up of 4 years. Half of them had a chromosome 3 status, a quarter had nuclear BAP1 stain. We constructed a chromosome 3 loss prediction model using 11 predictors listed here. We have a very good AUC curve. The nuclear BAP1 stain contributed to over half of the prediction power. We want to get rid of all the genetic test requirements, so we deleted our chromosome 8q gain and came up with a simplified model with 10 predictors. And you can see that the area under the curve is still good at 88%, and the sensitivity and specificity is around 80%. We further want to look at the actual prognostication value of the predicted chromosome 3 status. The LUMPO3 algorithm was constructed using over 4,000 cases in the UK It has been externally validated, is available online. The prognostication predictors included clinical, histopathological, and genetic features. Here, we replace the genetic features with the BAP1 predicted chromosome 3 loss model, and we call this the BAP1-based LUMPO. We compare the performance of this LUMPO against the benchmark, which is the genetic-based LUMPO. As a result, we can see this calibration graph. The metastasis risk according to BAP1-based LUMPO is mapped against the benchmark, the genetic-based LUMPO. So if they were of exact match, expect to see a diagonal line like a red line here. But as you can see, the dots scattered around the place, and the exact match were only 38%. So that is not very ideal. But if you give them a bit of room for error, you can see that actually 87% of the prediction according to the BAP1-based LUMPO falls within 10% from the reference. So that is actually not bad. We further look at the surveillance planning. In Liverpool practice, if you have a predicted metastasis risk over 10%, then you will be put into the high-risk group and require a regular liver surveillance. So we can draw the 10% threshold on the graph and come up with all the different quadrants. So actually, whether you use BAP1-based LUMPO or genetic-based LUMPO, the surveillance decision will be identical in 94% of the patients. 4% of patients, they fall within the over-surveillance quadrant. That means they have actually the lower risk, but will be put into the high-risk group based on the BAP1-based LUMPO. So these patients are still within the safety net. The more concerning patient is not a lot, only 2%. They will fall into the under surveillance category, meaning they have high risk but will be put into the low risk group based on BAP1 based LUMPO algorithm. So in conclusion, we constructed a model that accurately predicted chromosome 3 loss without needing the actual genetic testing. So the BAP1 based LUMPO, the metastasis risk prediction, 87% fall within 10% from the benchmark prediction, and 94% the surveillance decisions will be identical to the genetic-based LUMPO. So back to our initial question, yes, it is possible to predict chromosome 3 loss without genetic testing. What we really need is BAP1 immunohistochemistry staining, and this is a simple and cheap and a practical way to improve survival prognostication, especially in this part of the world. So I'd like to thank my mentors and my colleagues in the Liverpool Ocular Oncology Research Group, and thank you so much for your attention. Thank you so much.
Thank you, Dr. So, for wonderful presentation. We have Yakmer Yesitas, Dr. Yesitas, next. The title will be Iris Melanocytic Tumor. Please.
Yeah, hello. Good morning, everyone. First of all, a big thank to the organizers for organizing this such a wonderful meeting. I'm truly honored to be here and in front of you, such distinguished scholars. Today, I would like to share a case of iris melanocytic tumor that we followed with Dr. Arun Singh during my fellowship at the Coli Institute in US. A 54-year-old female was referred to ocular oncology service at Coli Institute because of a pigmented iris lesion with uncontrolled glaucoma in the left eye. She had a background of pathologic myopia and was being followed regularly by an optometrist. She had started using anti-glaucoma drops just 1 week before being referred. At presentation, the vision was 20/30 in the right and 2100 in the left side. The IOP in the right eye was totally normal, but in the left eye it was 54 despite medications. This is okay. Slit-armed exam revealed corneal edema and a small darkly pigmented iridociliary lesion with pigment diffusely scattered across the anterior iris surface. On gonioscopy, we saw diffuse circumferential pigmentation of the trabecular meshwork with a wide open angle. There was a marked pigment accumulation, especially inferiorly. On fundus examination, the cup to disc ratio was 0.3 in the right eye and then 0.7 in the left. A UBM showed a well circumscribed iridociliary lesion about 2 mm in thickness. Our differential diagnoses included iridociliary melanocytoma and melanoma. To clarify the diagnosis, we performed the FNAB of the main tumor, sampled the anterior chamber cells, and did an anterior chamber lavage. Cytology revealed polygonal cells with dense intracytoplasmic pigments, which obscured the nuclei, a classical finding for melanocytoma. In the first image, in the above, you can see a uniform population of heavily pigmented tumor cells. These were the only cell type present. No spindle cells were seen. At higher magnification, you will see the large pigment granules that make it difficult to see nuclear details. Given the clinical examination and cytology findings, the patient was thought to have an iridociliary melanocytoma with pigment dispersion causing secondary glaucoma. At postoperative 1 month visit, the IOP remains high at 41 and pigment had reaccumulated in the inferior angle. Since the tumor was still shedding pigment and IOP remained elevated, we decided to proceed with tumor excision with iridocyclectomy. Here is a short video of the surgery. We started with a conjunctival flap, followed by the outer and the inner scleral flaps. After making the UVL incisions, we were able to complete the resected tumor. You are seeing all the pigmentation all over the ocular surface. Histopathology showed a mostly necrotic melanocytoma made up of heavily pigmented plumb and polygonal cells. At higher magnification, there was a mix of polygonal type 1 cells and some spindle type 2 cells. At 1 month after surgery, the IOP dropped to 13 with maximal therapy. She eventually required glaucoma shunt surgery. 6 months after glaucoma surgery, her IOP was stable at 10, her visual acuity was 20/50, and no pigment shedding was seen. In conclusion, a pigmented iridociliary tumor with secondary glaucoma should always raise a suspicion for melanoma, but melanocytoma must be in the differential as well. Importantly, diagnostic FNAB can help establish a definitive diagnosis before any treatments, like radiation, excision, or enucleation. Although rare, necrotic melanocytoma can lead to severe pigment dispersion and secondary glaucoma. Surgical excision of the primary tumor, coupled with glaucoma surgery, proved effective in controlling IOP and preserving in our case. This is actually my first visit to India. I would like to sincerely thank to everyone, especially Dr. Arun Singh and Dr. Anna Singh, for incredible hospitality and warm welcome that I received here. It's truly a pleasure to be here today. Thanks for attention.
Thank you, Dr. Yesilta. The next speaker, Dr. Rubens Belfort. The title is very interesting, Second Opinion in Ocular Oncology for the GP, the OncoPhone.
Good morning. Thank you, Professor Singh, Professor Honavar, for the opportunity to be here in India. Is always a great pleasure. I brought my own photographer. Come on, we have to document things, guys. Is it good? Okay, so most of you in the audience work with ocular cancer, but let's think about the general ophthalmologists. And you've seen a number of presentations today with different kinds of cancer, different symptoms, very specific ways to treat these patients, not only to save vision, but also to save life, right? So here you have a squamous cell carcinoma of the surface of the eye, very common in India due to the UV you're exposed to. This is a patient with conjunctival melanoma. Might be necessary a wide resection. For you, it's very obvious. Room Singh is thinking this is ocular adnexal lymphoma. You're right, Dr. Singh. How about this one? But maybe for the general ophthalmologist, this is a more difficult diagnosis. And of course, we have metastases going to the eye, primary uveal melanoma, retinoblastoma. And Dr. Singh might have more precise data, but if you ask ChatGPT, the general ophthalmologist in Brazil will diagnose a choroidal melanoma every 20 years. So how can you keep this guy up to date on everything he needs to know to establish the diagnosis and treat these patients? So in the end, we receive very advanced ocular cancer cases, like this poor girl, or these carcinomas. I don't think you get many of these in Taiwan, but we do in Brazil. So how do we change that? Our idea was to create a YouTube channel explaining to general ophthalmologists how to treat these tumors. An Instagram just to remind them of ocular cancer. Of course, we keep teaching general ophthalmologists, but the idea here is not to treat them, teach them every detail of the treatment, but offer them a way to establish the diagnosis and know if this patient needs to be referred. There comes the Oncophone. It's a free consulting service through WhatsApp, only for ophthalmologists. We don't reply to patients. This is not for consultation of patients, just fellow ophthalmologists. Informal, very safe, fast, and this is how it works. Every morning, we get a couple of messages. Again, it's very informal. A picture, what should I do? And we try to help these colleagues. So here, a very brief video. Retina people, the macula is normal, relax. But if you see, this is done with a phone and a 20 diopter lens. And chirpy, right? No chance of progressing to a melanoma, no need to refer this patient to a center, sometimes very far from where he lives, right? So we took a look at the data, 4-year review. We got 1,055 consultations from ophthalmologists. You know, most anterior segment, we worry about that. Probably people are not dilating pupils enough in Brazil to check the back of the eye. Very few pediatric cases, but half of them we thought of retinoblastoma, and we advised for the ophthalmologist to refer this kid to a tertiary service, okay? The less advanced cases, we try to help the ophthalmologist to treat. So we advise on no-touch excision, biopsy, and of course, if possible, to refer the patient to a specialist. Of course, this is far from ideal, right? Everyone deserves someone, Dr. Honavar or Dr. Singh, to take care of their ocular cancer. But in a less ideal world, we try to provide help, and it's very easy. Any ophthalmologist in Brazil gets our number, and you see we get 2 or 3 consultations every day. I know in Europe and United States you would be arrested for this, but maybe in Asia, the system where you work would allow for a method like this to aid the general ophthalmologist and help our patients. The Oncophone doesn't pay much, so I have my side job here. If you guys need a tuk-tuk, let me know. I'm a very good tuk-tuk driver. India has been very kind to us. मैं ब्राज़ीलियन हूँ, फिर भी दिल है हिंदुस्तानी. Thank you, Dr. Singh. Thank you, guys.
Thank you so much. Ruben has an Indian wife, right? Yeah. Okay. So we have Arun Singh back again. He's going to present on behalf of Annapurna Singh. He'll speak on malignant glaucoma.
Yes, sir. Most welcome.
So I just want to touch the topic on of glaucoma. Am I not seeing my slides? Okay. So just labeled it a real malignant glaucoma. And Anna and I, we kind of prepared this talk together. We say, but we know tumors can cause glaucoma. We see that all the time. But don't forget, in glaucoma clinic, once in a while they see a patient that has an underlying tumor. So glaucoma can also be caused by tumors. That's just the other way to think about it. And of course, the treatment is rather complex. You have to think about individual patient, what kind of tumor, and also think about the comorbidities that the patient may have because of the tumor. So let's touch upon some of the key components. So glaucoma, we say, at least in this setting, we don't really look for visual field defects, okay? Why is it going forward by itself? And it can happen due to benign or malignant tumors, even in metastasis. It can be present initially, concomitantly, could be a sequelae, or iatrogenic from a treatment like radiation, for example, or steroids. Depends upon the type of the tumor, the location of the tumor, and the size of the tumor. We understand that in broad terms. It can be of open angle, closed angle, or neovascular type. I think this is very important. Glaucoma can lead to diagnosis of tumors, but not also just that, can be prognostic, at least in management of some tumors. We'll talk about some examples. General treatment, like in glaucoma, start with topical treatment and think about minimal invasive procedures. And in aggressive glaucoma, when the tumor is controlled, you can think about tube procedure. And MIGs are generally preferred, but you need to have really evidence of regressed tumor, and you really are concerned about extraocular extension. Let's look at some of the aspects or nuances of this. So when you have patient with tumor and glaucoma, it's not just two things, 1 + 1, there's more. You have certain problems such as dry eye from chemotherapy drops or radiation that patient had, so you need to take care of that. Patient may have conjunctival scarring, so you say, I can't really use a trabeculectomy here. Patient may have synechia or issues of the iris, and you say, I need to deal with that. Patient may have concomitant cataract, so you have to take care of that. Patient may have radiation optic neuropathy and retinopathy that kind of reduces the risk of good vision potential there. And of course, you always worry about creating more trouble than what patient already has, the risk of extraocular extension from the procedure. And always keep in mind that some patients may have shortened life expectancies, such as melanoma, so you really have to think about that also when you're offering your treatment. So let's look at some of the examples. So we say, here's a patient with ciliary body melanoma and has angle extension. You can see a seeding in the angle. This patient has glaucoma. So if the patient has 360 pigment deposition, is melanoma, you think of enucleation as the treatment. Always have to look for pigmentation in the angle, so gonioscopic is essential, and you can see a lot of pigment here, even on the anterior lens capsule. So this is not pigment dispersion glaucoma. That's all just melanoma cells everywhere. So this eye, because of this glaucoma with melanoma, would be enucleation. So glaucoma is prognostic, okay? It's taking you to enucleation. And in some cases, if you just don't dilate like Ruben just mentioned, you're going to miss an underlying tumor that's at the back. Just look at the acquired heterochromia that's on the surface. This is a patient with neovascular glaucoma. Patient had treatment with plaque therapy some months ago and now has iris rubeosis and high pressure. You say, well, how do you manage this case? Well, it depends upon how the tumor is doing, what the vision potential is, and is there any risk of metastasis here to the patient. Let's say, for example, this tumor is well regressed, it's on ultrasonographic measurements, is more than a year. from the treatment, the vision potential is expected to be better, and there are no other complications. There's no vitreous hemorrhage, for example, and he doesn't have any metastasis. You say, okay, I want to save this eye because there's some vision potential. You'll do anti-VEGF injections, you'll do PRP, and think of tube when that is settled. That's one way to deal with this. Alternatively, if the tumor is regressed, but the vision is hand motions, there is vitreous hemorrhage, the patient may be starting to get mets, you say, no, really, I can't be doing tube or trab or anything. I just want to do something palliative, give some steroids, dilating drops, maybe CPC if that doesn't work. So all of it depends upon how you're managing the glaucoma, depends on what else is happening to the patient. We talked about after radiation, it's not always neovascular complications. You can have what's called melanomelitic glaucoma, which is pigment-laden macrophages, many times leading to enucleation. Example here, regressed melanoma with a lot of macrophages laden with pigment in the angle causing secondary angle closure glaucoma. Okay, this is not my case, this has been borrowed. We talked about neovascular glaucoma in the setting of retinoblastoma. In my mind, if there is neovascular glaucoma and retinoblastoma, enucleation is the treatment. And not only just that, for example here, we showed this case earlier, the eyes has to be enucleated, but we also know this is a marker for high-risk pathology, right? So we know, at least in India, for example, we say maybe 50% of such eyes will have high-risk pathology. Not so much in other parts of the world, but that's a marker for, of course, high-risk pathology and need for adjuvant therapy. So glaucoma here is prognostic for ocular survival and even the patient's own survival. So it alerts you to look into the high-risk pathology as shown here. We also know in pediatric cases, neovascular glaucoma is classic finding of medullary epithelioma. So if you see neovascular glaucoma in a child and you can't find the tumor, you don't know the cause for it, well, you have to look in ciliary body. And you'll only look at ciliary body if you do UBM. So if you have neovascular glaucoma in a child, you really must rule out medullary epithelioma. It's a classic finding. You must do UBM. And we know that such cases are overlooked. They have this, that, and the other, and medulla is missed for many years, for example. Here's a case that Seda presented, was a melanocytoma. So not everything that's dark and pigmented is a melanoma. Remember, in a smaller tumor with glaucoma, think of melanocytoma. For melanoma to cause secondary glaucoma, it usually is a large tumor. Here the tumor was only a few millimeters in size. So that kind of triggers you to think, oh, it's not a melanoma. A 3 millimeter melanoma is not going to cause secondary glaucoma. Keep that in mind. So when you're seeing small melanoma causing glaucoma, think of melanocytoma. So just little clues that you learned over time from your clinical practice. Here's a patient with neovascular glaucoma, where then mass with inflammation is a metastasis, is proven by biopsy, was it from a renal carcinoma. So we know metastasis can cause inflammation and it can also cause neovascular glaucoma. And this patient had plaque and intracameral Avastin. Here's a patient with a very subtle iris melanoma, but presented with secondary glaucoma. The melanoma really is not visible. You can do iris fluorescein, you can do OCT, and you start to see little shades of melanoma. It's a diffuse tapioca melanoma of the iris. That melanoma is translucent. We did the biopsy, had proton radiation, and eventually required a tube. This patient is out for 15 years, but this is after very years of stability, when you're feeling comfortable, then he had tube. Here's the last patient. I want to show you a patient with a lymphoma. This patient had unilateral, uncontrolled, open-angle glaucoma and was to be considered for trabeculectomy. That's the time somebody lifted the lid because they're looking at the superior area to think where to do the trab, and they find this kind of orange mass. That obviously was suspected of lymphoma. He actually also had uveal lymphoma, had ICG, ultrasound, etc. We gave him radiation, and lymphoma went away, and so did the glaucoma. So glaucoma was due to episcleral venous blockage, we think, and once we took care of that, his glaucoma settled. So just very briefly, if it's a mild glaucoma, less than 30, you can think of topical treatments. If a little bit more, you may have to use oral Damox. Things like Icostab, mannitol, Damox, IV are really not very useful. If it's preferable to do minimally invasive procedures because most of the glaucoma is due to blockage in the trabecular meshwork. So these kind of goniotomy-based procedures are very useful. We'll skip that part. Think about If it's more advanced disease, you think of tubes, not so much of trab, because it's like photocoagulation, the vision is poor, but not so much trab because there's inflammatory environment, risk of conjunctival scarring. So coming back to the glaucoma and tumor, it's not, just remember, glaucoma influences management of tumor, like in medulloretinoblastoma, melanocytoma, and the presence of tumor influences glaucoma management. So overall, you have to prioritize the management of tumor first, obviously, and then optimize the glaucoma treatment. Thank you very much.
Thank you, Arun. The last speaker would be Dr. Saumya Jakati.
So, good
Okay,
afternoon,
w-
everyone.
Yeah, with the topic of immunohistochemistry, when and how. Yes, please.
Thank you. I'm Soumya from LVPI. I'm a pathologist, so you need to see the view of tumors through my lens. So, this is what I'm going to speak on: the principle of IHC, the interpretation, pitfalls, and the troubleshooting, and how do you work up your case, and how do you choose a panel of IHC. So, I'll take this through a case-based presentation. So this is a 19-year-old female who came with complaints of protrusion of left eye for past 15 days. On examination, we see a palpable mass which is noted in the lacrimal gland fossa, and patient had inferior dystopia of the globe and lag ophthalmos of 2 mm and limitation of extraocular motility. CT scan showed an heterogeneous tumor involving the left lacrimal gland in the superior temporal orbit with multiple calcification and globe indentation. The superior rectus and the lateral rectus were not visualized. Margins were appearing fuzzy and the mass was pressing onto the optic nerve. There was no bone erosion noted. On MRI, it was noted to be a lacrimal gland lesion with a well-defined lesion at the skull base posterior to the right maxillary sinus and with a diffuse dural thickening, which was suggestive of an intracranial metastasis. Whole body PET CT showed soft tissue component indenting the brain parenchyma, and other lesions were in the scapular ribs, right iliac fossa, and sacrum. So the provisional clinical diagnosis was left eye lacrimal gland adenoid cystic carcinoma with intracranial metastasis. So this was the HPE of the tumor, where we have more or less monomorphous round cell population with traversing thick fibrovascular septae and necrosis. Now, the lesional cells, they were round with moderate cytoplasm, with a pale eosinophilic cytoplasm as well, and a round hyperchromatic nucleus. There were occasional mitosis seen. That's it. And the periosteum, the adjacent periosteum and the lacrimal gland were sent as well, and the periosteum showed involvement of the tumor, whereas the lacrimal gland was absolutely free of the tumor. So this was provisionally called as a malignant round cell tumor with periosteal invasion. Now what next? Is this diagnosis sufficient for us to move forward with the treatment? No. So we go ahead and do immunohistochemistry. Now, applications of the immunohistochemistry include the cancer diagnosis and classification, identifying the origin of the tumor for staging and predicting the prognosis, and in certain cases where immune-mediated diseases are there, we have to diagnose whether it is IgG4 related or not, and in certain cases of infectious diseases, and of course, for research purposes. So the basic principle of IHC is nothing but antigen is targeted with specific antibodies which are tagged with a detectable marker, which is either an enzyme or a fluorescent probe. So there are various detection methods, like the direct method, which just uses a primary antibody and an enzyme over it to detect the antigen. Then you have an indirect, where you add a secondary antibody and an enzyme to detect it. In the bridge method, you have a tertiary antibody, which is bound to the enzyme and that detects it. In biotin-avidin method or streptavidin method, you have a basic body of streptavidin, which increases the sensitivity of the detection. And you also have a sandwich method, where you have more of streptavidin added, which binds and creates a bridge kind of appearance, and that is used to detect the antibody. Now in tyramide, which is an aromatic based derivative of tyrosine, that is used for signal amplification in this particular technique. and that also is used to increase the sensitivity of the detection of the antibody. And in rolling circle amplification, this was primarily used as a PCR method, but later it was developed as a technique for antibody detection, where they use a DNA primer and they create a circular template which is bound to an enzyme labeled probe, and that detects the antigen. What we technically use in day-to-day practice is nothing but a polymer-based IHC technique, which uses the formalin-fixed paraffin-emitted tissues. We use heat retrieval, antigen retrieval system, and this is the section of the enucleation block where we have to see that. So we take sections of 5 micron thickness, put it in the microwave with 3 cycles, and then the antigens are retrieved. You have to break the formalin bonds to expose these antigens. Now these antigens are located at various places, which is nucleus, cytoplasm, or the cell membrane, to which you add a primary antibody and a secondary, and then you add a HRP polymerase, which actually enhances the sensitivity of the technique. And then to that you add a diaminobenzidine chromogen, which detects it. And this is how you see under the lens the positivity of the antibody. So when you are interpreting IHC, you use various terminologies to say how is the antibody expression. First, we determine by saying the intensity of the antibody. Strong if it is shows very high level of antigen present in the tissue. Moderate if it is patchy and it shows a little bit of lesser intensity than the control, and weak or no staining when there is no antigen seen on the slide. Pattern of staining, whether it is diffuse or focal, and staining location, whether it was cytoplasmic, nuclear, or it was membranous staining. Then how do you troubleshoot when you don't expect these results to come? So this was a case of schwannoma, and the antibody ordered here was a Desmin. Desmin should not be showing up in a schwannoma. But what is that happening here? You can see that there was a control present in the tissue, which is brilliantly positive. But what happened here is that the tumor has already stained with Desmin. Why did this happen? So there was an inadequate blocking technique where the endogenous peroxidase activity was more. The antibody dilution might have been wrong, or there have been a cross-reactivity with the endogenous antibodies, or the technician might have not washed it properly. And the second thing, this was a case of prostatic adenocarcinoma, metastatic to orbit, and this is a pancytokeratin. Usually you expect this to be very highly positive, but what you see here is just a minimal, a faint stain of cytokeratin. Why did this happen? Because of the antibody dilution, probably the issue with the protocol, or the blast storage was not well, and there was an inadequate antigen retrieval. Now, this is an androgen receptor antibody. What do you think this might have happened? You can see that the control picture is in the inset, while there is a scant or very faint staining. What could be the issue? This could be because of the insufficient antibody, because few of the cells have been labeled or is showing expression in there. So this is another case of a lymphoma. So here you see that there is inadequate application of the antibody. Here what you see is there is endogenous cross-reactivity with immunoglobulins. Now coming back to our case, the morphological DDs here was orbital lymphoma, granulocytic sarcoma, poly or undifferentiated carcinoma, and Ewing's Barbinet. So we went ahead and did IHC with CD45, which was negative, CD20 was negative, MPO was negative, PAN-CK was negative, CD99 showed membranous positivity, Ki67 were quite high, and NKX2.2, which is one of the transcription markers for PNET. This was a case of Ewing's bar PNET. So coming to case 2, this was a 65-year-old man who presented with diminution of vision in right eye and associated with redness and pain. He was diagnosed elsewhere as ocular tuberculosis, and he had no improvement in vision and was referred to the oncology clinic. His best corrected visual acuity was 2320, and this was the fundus photograph of the patient, where it showed inferior subretinal exudate, and there was a creamy white multilobulated lesion with overlying pigmented changes and a hyperemic disc. The B scan showed multiple lesions in the choroid with a hyperreflectivity in the retina. This is the OCT, which also showed lumpy bumpy deposits in the RP, and there was hyperreflectivity in the internal layer of the retina. So PET-CT also showed a focal subpleural metabolic activity mass, which appeared like consolidation, and other than that there were mediastinal and hilar lymph nodes. Now this was the choroidal biopsy taken, which showed a faint acinar type of cells along with the retinal cells, and this was the morphology of the case, which also showed acinar pattern. Alcian blue was done, which showed intracytoplasmic mucin, and pancytokeratin was positive in this, and melanin A was negative. We restricted to do more IHC markers because the patient needed the block for molecular analysis. So we have to be very careful when the patient wants to take for molecular analysis. The block you have to choose a very, very minimal panel based on the morphology you see. So how do you approach a case? You have to first look at the morphology, whether it's squamous, or whether it's showing any acinar kind of morphology in adenocarcinoma, or a classic Indian file pattern like in lobular carcinoma. So you have to look at the morphology first and then decide what immunomarkers you're going to do. So next is whether you have to see whether it is of epithelial origin, and then you advise markers such as cytokeratin and EMA. Whether they are spindle, then you order Vimentin. If they are round cell, then do CD45 and other hematopoietic markers
So
first.
can you please
And
conclude?
then, yeah. And melanoma, if it is, then you do a Melanie. So this is the basic panel. So you do it in panels based on the approach. And to conclude, IHC is a very powerful ancillary tool which provides important diagnostic and prognostic information, and histopathology of the tissues should be the basis of the choice of markers, and they have to run in panels, and every laboratory has to standardize their technique, and controls should be perfect before you do the test. Thank you. And this is our team at LVPI. Thank you.
Thank you very much. We have about 15 minutes left for questions and discussions. Can we go by presentation? The first one was vitreoretinal lymphoma in children by Dr. Kwok. Any questions? Any comments? Go ahead.
Very nicely worked up case.
Arun, you can use the mic. Yeah.
That's a very nice case. In the conclusion, you mentioned that the diagnosis was based on cytology and NGS. I would say the diagnosis is based on cytology and corroborated by NGS. Is that a reasonable thing to say? Okay. Because we cannot really rely, if suppose this case cytology was negative, I don't think anybody would have given chemotherapy to this child.
Do you want to respond? Please come. Please come up to the mic.
Yes, I totally agree. Yeah, it's corroborated by NGS count. Yes.
Any more questions? We'll go to the second paper, that is management of intraocular vascular tumors. Any questions on that? Any comments on it? Please go ahead.
So thank you so much for the nice presentation. Just like to ask a general question about the treatment options, because I always heard that for vascular tumors, like hemangioblastomas, these kind of tumors, if you treat with cryotherapy, it's quite easy. You induce a massive exudative response, and so I just want to know about what's your priority when you choose the first treatment. Thank you so much.
We choose the treatment based on the location and the size of the tumor. If the location is in the periphery, we prefer cryotherapy. If it's posterior, I prefer TTT or PDT. And if the size of the tumor is thicker than 3 millimeters, then maybe plaque is the better option. But in terms of exudative response, you don't have to do the cryo very heavy at the first time. You can always repeat it. Usually I do double freeze thaw or triple freeze thaw, and then wait for the results. If it's not responding well, then I will add it again. So you don't have to do very heavy cryo at the first time. Yeah.
I agree with you, but if you add anti-VEGF to your cryotherapy,
Yes.
concurrent anti-VEGF, or if there is already an exudative response, if you give anti-VEGF injection a week before you perform cryotherapy, then the worsening of exudative response or the onset of exudative response itself will be blunted.
Okay, so anti-VEGF, but not like steroids. So which one?
Which one?
Steroids, corticosteroids.
I have no experience with intravitreal steroids for this condition, but I have used ranibizumab with very good results.
Thank you so much.
In case of exudative RD that is very, very severe, I would do an intravitreal triamcinolone before I do cryo or treatment, because you cannot see the tumor. But if it's thick, then you do the plaque. But I agree with Professor Honaver. I think intravitreal anti-VEGF before the treatment is very helpful. Yes.
Oh, so if there were a large exudative detachment, you will inject some triamcinolone.
Yes.
And then you wait until it resolves a bit before you do cryo. So that's 2 separate sessions.
Correct.
I see. Okay, thank you so much.
Or as an alternative, you can do brachytherapy. If you don't see the tumor physically, but you have located it on ultrasound, then and the height is higher, say more than 3 or 4 millimeter, which cannot easily be treated with cryotherapy, then you can do primary plaque brachytherapy as an option. The third paper was by me, ocular surface tumors for plaque brachytherapy. Any questions on that?
Very nice presentation as always, sir. I have learned from you that for diffuse tumors or for big tumors, we can do chemo reduction and then can do a surgical excision. But now in your presentation, I saw that for diffuse tumors you had used brachytherapy. So when will you advise to use?
Right. So for immunoreduction or chemoreduction, the principle is that these work on tumors. For say we're talking about ocular surface squamous neoplasia, these drugs work on tumors only if they have a component of dysplasia, mild, moderate, severe, or carcinoma in situ. Invasive squamous cell carcinoma does not generally get treated with topical chemotherapy or immunotherapy. So when there is stromal invasion already, it is proven beyond doubt that it is invasive squamous cell carcinoma, where topical therapy will not work for the stromal component. But for the rest of the tumors, it may still work. So you're only going to reduce the extent of the surgical excision by pre-treating them with topical therapy. At the same time, since it's an emergent situation where you have to do something expeditiously without waiting for 2 or 3 months for your topical therapy to work on rest of the tumor, I would prefer to do primary surgical excision here whenever there is stromal involvement already. That's the logic.
Thank you.
I have one question, sir. So I had one case where for the OSSN, there was a OSSN in the medial bulbar conjunctiva, and after excision it was CIN3 with one margin involved, which was likely corneal, and since the cryo was also done, the adjuvant chemo was not given. But after 1 year, the patient complains of persistent foreign body sensation, and when I see the tarsus, there was a recurrence in the tarsal conjunctiva but not extending up to the fornix. So in that case, what do you advise? So do you advise a full thickness lid excision or a plaque, or just removing the conjunctiva from the tarsus? It was maybe
Well, when there is tarsal excision, you can't do brachytherapy. With the devices that we have, we can't do brachytherapy. There's a new device design that is coming in which looks like a symblepharon ring, where radiation can be given both to the palpebral conjunctiva, fornicial conjunctiva, and the bulbar conjunctiva at the same time. Until that design comes in, you cannot treat palpebral conjunctiva easily, and you have to resort to surgical excision.
Surgical excision means full thickness, even if the anterior lamella is
No, you can do differential lamellar excision. If only the posterior lamella is involved, you can do posterior lamellar excision, sparing skin and orbicularis.
Thank you, sir.
I'd like to have another question. So about the arrangement of the different treatment. So if you consider surgical excision, cryotherapy, plaque, and topical chemo, so each of them will induce certain inflammations. And the worry is that you get some ocular surface problems after all these treatments. So just wonder, how do you arrange them, and how close you arrange all these treatments, or do you combine them together always? So, or it's highly independent on the patient's condition. Thank you so much.
Topical therapy is always used in isolation. Suppose you start interferon alpha 2b or 5-fluorouracil for ocular surface squamous neoplasia, you give it time for the drugs to work, and then if the drug is working, you continue with the treatment until there is complete resolution or there is stability. If there is stability, the tumor is no longer responding but has become smaller, that means that the residual component needs to be surgically excised. That's the protocol that we follow. Cryotherapy generally is not used in isolation unless you have a very small localized recurrence following surgical excision or topical therapy. Suppose the entire tumor goes away and you have just a 2 millimeter residual right at the limbus, perhaps that can be taken care of by topical therapy. When you do surgical excision edge cryotherapy is part of the surgical protocol. So that is done to the normal conjunctival edge, the so-called normal, clinically normal conjunctival edge, to take care of microscopic residual, which is not clinically apparent, which cannot be picked up on, say, OCT. So cryotherapy is part of the surgical procedure. We go on to the next paper by Arun Singh on chemotherapy in retinoblastoma, which route?
If not, maybe I have question.
Yeah.
Yeah, Dr. Arun, you mentioned about the route, the different route of the chemotherapy given to the retinoblastoma. So can you share also with us how is the order, the sequence, the arrangement of the order? Which one should be given at the first line and the second, etc.? Is there any clue for that?
Well, yeah, first you have to figure out just a way to think about it. It's a very complex topic, so I'll keep the answer very simple. You first figure out in your mind that this eye should be salvaged or should be enucleated. So let's say I figured out, because this vision potential is group D or E1 or whatever you want to call it, I've decided that globe preservation is the way I want to go. In that case, I would say IAC is a preferred method as primary, because we know IAC is superior than IBC for a group D disease. This is well established in many trials, retrospective studies, case series, and a randomized trial. So once you figure this out, but if the child is less than 3 months old, has maybe bilateral disease, I would say IBC is the first line treatment. But IAC can also be used for a recurrent disease. Simple.
Thank you. Rita, question to Rita Sitoris. She spoke on retinoblastoma treatments. Can we avoid radiation retinopathy? Any questions to her?
If not, then I do hope that nobody in this room will have a bad experience like what I presented. Thank you.
All right. So the next topic is Hyunda on choroidal melanoma prognostication without cytogenetics. I think it was a very good presentation. Any questions on that? Do you have any experience, any of the audience?
What happens if you take away the BAP stain? If you just look at the physical characteristics without even BAP stain in the model, people have published up to 85% accuracy.
Right. Shields paper on
So you just use
morphological
that one.
parameters.
Yeah.
In the model,
Yeah.
you took away, you substituted chromosome with BAP1.
Yeah.
If you just take away BAP1 and chromosome,
Yeah. And use the rest.
how much is it? 85?
So we haven't tried that in our model, but because as you can see, the model, the total prediction power is around 200, and 128 or so were contributed by BAP1. So that means I can, I think reasonably think that if you take away BAP1, the performance will be very low, and it wouldn't.
There are
Yeah.
other models. There are other models
Yeah.
that kind of can predict at 85% without any genetics. Without that.
Without BAP1. And what are the predictors they put inside the?
It's all about size, location.
Yeah, everything.
Tumor dimensions and morphology.
Yes. So there are a lot of models indeed, and I think the best way to take this forward is perform an external validation. Otherwise, it's everyone has their own model and performances, so
Agree.
it's very hard to say. Thank you so much.
Thank you so much. The next topic was iris melanocytic tumor from Yagmur Yersilas. Any questions to her? Okay. Rubens Belfort, Oncophone I think is a wonderful idea, interesting idea, applicable in Asian countries for sure, where there are not too many restrictions on sharing clinical information. So any thoughts on that? Okay. Arun Singh again, malignant glaucoma. Yeah. Anning Chau.
Yeah, I'm glad that Dr. Singh talked about the glaucoma in the oncology patients. I think this is not that uncommon for this specific group of, I would say, that vulnerable eyes. For example, as you mentioned, for retinoblastoma, if this happened at the initial presentation, you and you the eye. But I find it difficult to communicate with my glaucoma specialist. For example, once for example, a case with choroidal met, everything was fine, and then we know that it's choroidal met at the back of the eye, and then it happens to be the pressure is high again. We did the gonioscopy, everything was done. Then suddenly the pressure is high, then we use the topical, but it's usually very hard to convince them to do anything like open group, such as the tube. So how would you manage? Because I would say, and also the patients feel uncomfortable with like something going out. Even say the tumor was treated like years before. Yeah, and also the very hard patient with NVG as well.
I'll just make it a very brief comment.
Yeah,
In
please.
contrast to oncologists, glaucoma people are very risk averse. They just can't touch anything, so you really have to convince them. That's all.
Thank you so much. And last, Soumya Jakati, any questions to her? Immunohistochemistry. We can't work without pathologists, so. All right. So there are no more questions, and I think Rita you can close the session.
Okay. We finally be at the end of the session. I and Dr. Santos and Dr. Lee would like to thanks for your attention and participation. Hopefully that what we learned from this session would be useful for your daily practice. And thank you very much, and have a good day still. So may I ask all the speakers to come up to the stage for the photos group? Thank you.